land acknowledgement is a formal territorial acknowledgement through which we recognize the Indigenous peoples of Canada as the original custodians of the lands on Turtle Island, which was appropriated by European settlers during colonization. We must understand that there is no one right way to acknowledge the land. However, it is our responsibility to understand our positionality and privilege as settlers to become better allies.
Ani bojo, Nimkins Indigenous Oki Kendan Donjba Benishin Dondem Anishna Beninindao. My name is Connor Little Thunder Spirit Lafortune. I'm from Dokis First Nation and I am part of the Bird Clan. As an Indigenous person, I have an inherent responsibility to honor and respect the earth. I understand that due to the nature of this national project, we are not all on the same territories. I therefore acknowledge that the lands upon which we all reside and benefit from are called Turtle Island, where hundreds of nations, customs, languages, and practices live. I acknowledge and honor Shkugmakwe, Aki, Nebe, Shkode, Awisin, and Anikobjikin. These lands have been utilized and taken care of for millennia. I acknowledge and thank all of those who have worked these lands and continue to do so in order to give me a place to reside, work, and receive schooling. I acknowledge my responsibility as a tribal and treaty member on these territories, and the responsibility of all of my relation. I acknowledge my non-Indigenous brothers, sisters, and siblings who have found their home on these sacred lands. I follow the intents stated in the Dish with One Spoon Treaty and the Treaty of Niagara to share these lands and collectively play our part in caring for her. Miigwech.
A land acknowledgement is a first step. As settlers on this land, we are all treaty signers and occupiers of unceded territories, who often benefit to this day from the structures and practices of colonialism, and are therefore responsible and accountable for the violence that Indigenous people face. Allyship is a continuous process, one you earn from the communities you stand in solidarity with through your actions and commitment. We can recommit to being better allies through continuous efforts in the Truths to Reconciliation process of the Indigenous people's history. And we can stand in solidarity with them, which would begin by listening to the various Indigenous voices and their efforts in indigenizing their lands, communities, and history.
Yeah, so it's always important to start our meetings with land acknowledgements and really work individually on our positionality and centeredness in these issues and to always work towards decolonization and strengthening all of our journeys in this path. So I am very excited to welcome all of our panelists today. We have several experts, as I mentioned, and so what we'll do is we'll just allow everyone to introduce themselves, sort of on the order on the screen, just about their backgrounds and what they are bringing to the discussion. And yeah, so I'll pass it off to Dr. Didier Jutras-Aswad.
Hi, everyone. Very happy to be with you all. I'm Didier Jutras-Aswad. I'm an addiction psychiatrist by training, also a researcher here at the University of Montreal Hospital Center. And I've been one of the co-authors of actually of the Lower-Risk Cannabis Use Guidelines for psychosis that we'll talk about today. So again, very happy to be here with colleagues and different folks to discuss about and talk about these recommendations.
Hello, everyone. Thank you so much for joining in today. My name is Kalpit Sharma. I'm currently a student. I was a student at York University. I did psychology there, and I'm a person with lived experience of psychosis. I've been struggling with psychosis for the past 2 years, and I'm really excited to be here to talk about the low risk guidelines about cannabis use.
Hi, everyone. My name's Heath. I use they, them pronouns, and similarly to Kalpit, I'm a person with lived experience of cannabis-induced psychosis. I had a single incident of adolescent psychosis between grade 11 and 12 quite a few years ago, but I've done a lot of work doing like lived experience storytelling around what that was like for me, and that's what I'll be doing here today. I work with the Cannabis and Mental Health Project, and I was actually fortunate to be one of the peer reviewers for the lower risk use guidelines for cannabis and psychosis, so I'm really excited to see them presented today and excited for everyone to be here.
Hello, everyone. My name is Arman Fallahi. I'm a medical student at the University of Toronto. For me, I have been working with the project first with Cannabis and Psychosis, and now with the Cannabis and Mental Health project, working towards developing knowledge and synthesizing knowledge to share about cannabis and mental health and cannabis and psychosis. I'm interested in particular with how these resources are able to facilitate dialogues between clinicians and individuals, and also the impact that they can have in our society, and the levels of decision making that people make as they make their own informed decisions. And so really excited to sit and help moderate this panel today.
Great, and I'm David Crockford. I'm a psychiatrist in Calgary. I've been in practice for the past 25 years and lead up our early psychosis program. I work also at the addiction program where I've been a consultant there for many years. I was the lead author for the Canadian Schizophrenia Guidelines, which looked at specifically comorbid substance use disorders and psychosis. So super excited to be here.
That's great. I'm glad that we got to hear from all of our panelists today. We'll hear a bit about the guidelines themselves from Dr. Jutras-Aswad in just a moment. Not sure if Sarah will be sharing her screen for the presentation, or perhaps Didier.
Sarah was supposed to do so, but if
Yeah,
needed,
not
I
sure.
can jump in.
Yes. Sarah, are you there? You stopped sharing your screen.
I'm getting there. One sec. Sorry, guys. Thank you for your patience.
Fantastic. So maybe, Arman, is it time for me to take it from here?
Please, yes, the floor is yours. We're excited to hear about it.
Fantastic. So I'll spend probably the next around 10 minutes just to present you kind of an overview of the work that's been done over the last few months, leading to actually the publication of the Lower-Risk Cannabis Use Guidelines for Psychosis, but also, as you will see, a number of other materials and tools that can be used by people who are using cannabis, as well as clinicians and other stakeholders, of course. And this project actually started probably a few years ago. So some of you may know that there's been lower-risk cannabis use guidelines that were published many years ago, and have been actually used, disseminated, and actually discussed quite a lot, which basically provide a number of recommendations for, I'd say, the general population about tips and suggestions on how to use cannabis in a way that is less likely to result in negative outcomes and more likely to result in a more positive experience. And I'd say after and this work was conducted, was very useful, recognized as such by many. A lot of people, though, looking at these guidelines, were also highlighting the fact that for a number of people, including for people with mental health, the risk-benefit ratio and some of the recommendation were not necessarily well adapted. And an example of that was, for example, that for people who do have a mental health problems or disorder, actually kind of the recommendation was quite simple, that these people should probably not use cannabis or decrease as much as possible, without a lot of nuances, and also knowing that actually a lot of people with mental health disorders are using cannabis and are not necessarily interested in decreasing or ceasing their use. So I'd say that there's been a growing interest in the last few years to work on along the line of the initial lower-risk cannabis use guidelines, but to work on kind of more adapted recommendation for people who are at risk of psychosis, who experience psychosis. Again, with the same, I'd say, general thought and idea, that is that, of course, if you want to be absolutely sure that you will not experience any kind of negative experience with cannabis, the easiest or simplest way to move forward is just not using cannabis. But that for a lot of people, this is not initially what they want to do, and they still want to use cannabis, and that there are other options and recommendations that these people can use to actually decrease the risk of having negative outcomes of cannabis use, and on the other end, I'd say having a more positive experience of that use in a safer way. So that's what really led a group of people with different expertise around substance use, cannabis, mental health, to work on these recommendations. And so what we've done with these recommendations is really look at the available science on cannabis, mental health, more specifically psychosis, and beyond just the link between cannabis and psychosis that we've been talking about for so long, but also trying to get into the details and the nuances, the literature and the science, looking at, is there any kind of factors, and with a lot of emphasis, I'd say, on, is there any kind of behaviors that can be modified by people who are using cannabis that actually can lead to a safer way of using cannabis? And so doing that, we did a kind of a thorough literature review. There's been a lot of discussion, and we came with a number, actually 11 recommendations for cannabis consumers on way actually that they can use cannabis in a safer way, and mostly focusing on psychosis outcome, but not only on psychosis outcome, as you will see. And so these recommendations were published in the last few months. So we can, I'm not sure if I can, no, I cannot. So if possible to change the slide. So what I will do now is actually go a little bit over these recommendations, what we came up with. Just a note, and I'll say it right away, and I'll come back to that later. What I'm doing here is to really present you the recommendation in I'd say kind of more scientific, even it's not overly complex, but more scientific term. What we've done, and I'll show it to you after, is that, of course, there's a difference between when you look at science and when you try to summarize scientific data, and how you should convey the message and how you should actually discuss if you're a clinician, for example, how you can discuss cannabis use with someone who's using cannabis. If you're someone who's using, the type of information and the type of language you want when you want information about cannabis. So we develop a number of materials and tools that I will discuss later on, using, I'd say, more appropriate and adapted language. What I will present you here is really the core content of it, not suggesting that the language you'll see here is exactly the term and the language that we'll use when we want to discuss cannabis use with someone who's using cannabis. And it's actually not necessarily exactly the language that is used in all the tools that we develop. So, one of the first, and actually we did a little bit like the first, the original Lower-Risk Cannabis Use Guidelines, acknowledging that indeed someone with a family or personal history of psychosis, if they haven't initiated cannabis use, the easiest way to avoid any kind of negative consequences of cannabis is, of course, not using or not initiating cannabis use. But in the recommendation, we quickly moved to the idea that for a number of people, and actually when we look at the information we have from a number of studies, there's a good number of people with psychosis who don't necessarily want to stop using cannabis, and there's a number of other things that can be done. And the second recommendation is actually notably for those who haven't started yet using cannabis and are thinking about potentially using cannabis. One of the best way to decrease the risk of experiencing, for example, psychosis related to cannabis, is to actually delay as much as possible the start of using, knowing that actually we do have some data showing that actually the earlier you use, the more likely you or the higher risk you have of eventually experiencing psychosis related to your cannabis use. We also looked a little bit into people older age, and we're talking usually about people over 60, 65, for example, and we do have some signal that actually those people may also be at higher risk of experiencing negative consequences in terms of the mental health of cannabis, and again, suggesting that these people should avoid intensive use. A lot of and I think that the third one is a key component of the recommendation, really focusing on actually the cannabis content. And I'll come back to this, but I think that's one interesting piece. My experiencing with actually interacting with people who use cannabis, including some people who are seeking mental health care in my work as a clinician. The type of cannabis product that is used is often very, I'd say, good first step and more accessible first step, and sometimes cannabis use patterns or behavior that can be changed a little more easily than, for example, decreasing their use. And it's actually trying to use cannabis that may have lower THC content, lower percentage of THC, especially if some people who are using regulated product, they do now have access to the percentage of THC that the product contains. So that's another of the recommendation. One also thing that we underlined and highlighted in the recommendation is regarding CBD. There's been a lot of talk about CBD, cannabidiol, which is another common content of cannabis, and it's been also almost advertised as kind of a treatment for psychosis. It's been advertised as a kind of a protective factor. And basically, when you look at the data, we don't have very strong data supporting the idea that, for example, CBD on its own is sufficient to protect against for example, the risk of psychosis related to the use of very high THC level kind of products. So we just say here that it's for sure it's probably a good thing if you're using cannabis to use cannabis that have high CBD content as opposed to high THC content, but people should not use the CBD high CBD content as a way to guard against the potential negative effect of products with high THC in it. So we can come back to this if that's something of interest. We talk a little bit. We talk also about the fourth recommendation about frequency, of course, and that's probably one of the best factor that predicts whether or not someone will develop negative consequences of cannabis is when the use is very frequent. So we remind again that the more often you use cannabis, the more likely you have to have some risk of developing psychotic symptoms. So that's another recommendation. Next slide. Modes of use. So that's an interesting one because we spent quite a lot of time, the group of authors of the recommendation, about this. And what we ended up with is, when you look at the literature, is that there is no mode that is incredibly better than the other. Each mode of use, whether you're smoking cannabis, whether you're taking oral products or with food or whatnot, each of the mode of administration has its own risk and its own advantage in terms of health. So what we're really, and I don't have the time to go into the details of it here, but what we're trying to highlight here is that each mode has its own risk and advantages. And basically when someone is using cannabis and want to explore a different mode of administration, that person should be aware of actually the risk and benefits and how to use each of the mode in a safer way, because there's a number of things that can be done so that you know how to use. For example, when you take THC in food products or whatnot, there's a way to do this in a way that is less likely to end up in negative consequences. We remind also that often people use cannabis may use other substances, and actually mixing substances and actually using multiple substances increase your risk, including for your mental health. So sometimes it's maybe about trying to make a choice between substances, trying to avoid to combine those substances. So that's another recommendation. We talk a little bit about when someone is experiencing psychosis, is using cannabis actively. We talk about the idea that this person it could be kind of a good timing to try to reduce or stop cannabis use, and that for those who are not able to stop their use, that actually it's sometimes probably a good timing to switch to CBD-rich product instead of product that contain high THC. Again, for those who may not want to stop at that time, if that's not what they wish to do. We also discuss a little bit in the recommendation medication interaction. When you're using, especially for those who have psychosis, who are taking antipsychotics, some of the medication may interact with cannabis, and especially if you're smoking cannabis, for example, and especially if you're smoking cannabis with tobacco product. And so we discuss a little bit this and the risk of actually the cannabis affecting the level of antipsychotic in the blood and the efficacy of these antipsychotic or treatment. And we also advise to discuss this with the clinician to see how this person, whether or not they want to stop using cannabis, how they maybe should make sure that first they take their medication, but also maybe if that need to be adjusted, that's taken into consideration by often the physician that will prescribe the medication. Next slide. So we also discussed these findings, actually, that we see that there are benefits for mental health and for health in general of having breaks of cannabis, even if you don't stop necessarily permanently, but having sometime breaks of using for a little while can have its benefit. So for those people who are not necessarily ready to commit to stop completely forever, that they can, of course, reduce the intensity of use, or actually even take some of these breaks, have maybe sometimes timings that are better for them. Either it's on vacation or they have a break, or for whatever reason, sometimes maybe it's better timing, and have these kind of breaks of cannabis use may be good for the brain, good for their mental health, and also sometimes help these people experiment how things are going without cannabis and see if that changes a little bit their mindset about using cannabis or not in the future. We also discussed the combination of risk factors. So basically, one thing also we see is that, of course, when you're using and you have one of the risk factors that we discussed until now and that I mentioned in the last few minutes, you increase your risk of psychosis. And when you multiply this risk factor or combine these risk factors, so for example, if you're using at a time where you do have psychotic symptoms and on top of it, you use THC, a product with high THC content, and you use those products very frequently, then you're starting to combine and adding these factors, the risk factors, that can actually have a negative impact on the risk of doing well in terms of your mental health. So that's, again, another recommendation of trying to avoid combining different behaviors or way to use cannabis that can lead to increased risk. And what we also remind is, of course, these recommendations are focused on psychosis, but cannabis can have other health consequences. So we also remind of other consequences of cannabis. For example, when you're smoking cannabis, it can have an impact on your pulmonary health, your respiratory health, your lungs. So basically, we're discussing a little bit of the other risks that it can present above and beyond the risk of psychosis, so that people who are using cannabis are well informed about these risks beyond mental health. Next slide. And so, again, we do not pretend here that these recommendations are necessarily like clinical guidelines or that they should replace treatment. We basically develop these guidelines more in a way to inform, first and foremost, inform people who are using cannabis about the evidence, the data, the science, help them making informed decision about their cannabis use. We also think that actually these type of recommendation could be useful for clinician, maybe helping and could be integrated in the discussion between clinician and people who are using cannabis and do have psychosis, for example. I'll come back to that in a moment, but with my experience in having feedback from a lot of people who are doing that type of clinical work is that sometimes they feel that those discussions are not necessarily productive. Sometimes people who use cannabis who have psychosis also sometimes feel that they don't feel comfortable talking about cannabis, because sometimes it also end up being a discussion around having to stop using cannabis, which is not necessarily what they want to do. So these recommendations were also developed with this mindset of having kind of healthier, more productive discussion between people with psychosis and who use cannabis and clinicians, and a number of recommendation that could be, I would not say easily, because changing the way we use a substance is often not necessarily easy, but kind of low-hanging fruit or kind of behaviors that can sometimes be changed. For example, using cannabis with lower THC content, that doesn't necessarily imply to decrease the frequency of use or whatnot. Buying from regulated channels. So we do have in Canada, of course, regulated sources, legal sources to access cannabis. So doing so, basically purchasing cannabis from these sources, allow also to have information about what people are using. So that's also a good way to use that information and be informed about the product that they're using. Talking about the breaks, sometimes committing to completely changing your cannabis use forever is a kind of a huge commitment, which we all fully understand, but having some breaks sometimes is a more reachable goal in the short term. And sometimes reducing amount in terms of gram, for example, could also be not necessarily talking about stopping completely, but just decreasing a little bit of quantity, and can have an impact actually on the well-being, mental health of the person that is using. Next slide. And so when I was talking a little bit about the fact that, of course, the scientific review and everything led to recommendation that were not necessarily tailored in the way with the language we want when we want to discuss cannabis in a more kind of ecological context in the clinic, for example, or someone who's using cannabis who want to have access to that information. And so that's why we also, following the development of these guidelines, develop a number of kind of materials that would synthesize, for example, summarize a little bit of the recommendation. You have example here, sometimes much shorter, and of course the full scientific article that is a little more detailed and written in a more of a scientific kind of wording. So that's also the type of products that we develop in a way and with a language that is probably more appropriate for people that may want to use those kind of tools. Next slide. We are also thinking about clinicians. We develop a number of tools and material that can be used, that goes from posters that can be put in the clinic, and mostly, as you will see here, focus on the idea that highlighting the idea that clinician, they should and they can be open to discuss cannabis and in a more open manner. There's a journal decision aid that is for actually someone with psychosis who use cannabis, who want to think and be walked through how to think a little bit about their cannabis use above and beyond just the idea of stopping their use. And we also developed a dialogue support tool for clinicians and also other materials that about how to communicate around cannabis use with people with psychosis. With, again, the feedback from people with psychosis who use cannabis, saying that sometimes they feel pressured with some objective that they're not theirs. That's often discussion is centered around stopping their use, while sometimes that's what they want, but sometimes that's not what they want. Some people saying that they sometimes feel judged a little bit, are stigmatized around their cannabis use in clinical settings. And on the other end, a lot of clinicians sometimes feeling that they want to help the patients or the person they have in front of them, but sometimes not feeling comfortable discussing about something else than purely cannabis cessation. So it's a number of tools that discuss not only the content of what could be discussed following the recommendation, but also how to bring the discussion. What's the tone? What's the good timing to discuss this? How to bring the topic without, to make sure that the person that you want to talk with, it doesn't feel stigmatized and that the discussion is not perceived as judgmental. So a number of tools derived, I'd say, from the recommendation that will also be useful to facilitate a little bit discussion with clinicians. So I'd stop here, kind of very quick overview of the recommendation, just to start a discussion, but just so that we have common understanding a little bit of the recommendation, the tool that are made available for both people who use cannabis and have or psychosis, and also clinicians.
Yeah, thank you so much for sharing that. It seems like a really good basis for the discussion, and a lot of research has gone into preparing not only the guidelines, but also these toolkits and these tools that can help various aspects related to cannabis use and psychosis. So for the question period now, just so we can all be on the same page, we have some prepared questions that we feel will help spark discussion, help meet some of our learning objectives for the session today. But we encourage you all to please add questions in the chat. We'll be monitoring that, and after we get through our questions, we'll bring it forward for the panel to address. And yeah, we'll be monitoring those, and if we feel that we want to bring them up because they're relevant to the topic of current discussion, I'll assess that, and then I'll bring it up to the panel as a question. So for the first question, Dr. Jutras-Aswad, I think this is for you. Specifically, you were going through and emphasized really that the guidelines are a synthesis of the research and not necessarily exactly meant for digestion by the user, for example. Can you expand and tell us, maybe start off our discussion on how can these guidelines be helpful for people who use cannabis, whether it's broadly or with some nuance? And that can sort of start off our first question.
Yeah, I think there's different ways, some that are obvious and that we thought and we developed some tools, and I'll come back to that. And some other, I'd say some other ways that maybe a little bit indirect and less formal, but I'd say the first, and I think the most obvious use of them is to inform and inform people who are using cannabis. just providing people who use cannabis who may have psychosis, may not have psychosis, with what's the state of the evidence. And I think there's a value in use to that, just because there's so much said about cannabis these days. We hear, in the general media, and even scientific articles, and it's all over the place. Sometimes in a very dramatic way. Sometimes we hear something, we hear the completely opposite thing a few weeks after. It's very difficult to kind of find out where is the science with all that. And so the first goal for the group was actually to just provide what we think is the state of the evidence in terms of science on cannabis and psychosis. Again, going beyond just the idea that stopping cannabis is the only way to go. So providing that information and help people make choices about their cannabis use in an informed way was the first goal. Same thing again, and it's a bit along the line of what I mentioned, but I also think that especially for people with psychosis and in clinical settings, I think that there have been so much said about the risk of cannabis for psychosis and the link between using cannabis and developing psychosis, that a lot, I think, in many clinical settings efforts have been focused on how to make people use cannabis stop to use cannabis to avoid all psychosis risk, which does not reflect actually what a lot of people are willing to do and want to do, and also does not reflect, and I can go further, does not reflect the reality that some people with psychosis and mental health problems will use cannabis without necessarily always experiencing negative consequences, including for their mental health. So there's a variety of experiences with psychosis, and reflecting that with this work and these recommendations, we thought was a useful addition that could help. And that's maybe the more informal objective and use of it, is also a little bit change the way we approach cannabis for people with psychosis. And I'd say a more harm reduction approach. And there's a number of clinicians, and well, I know David now for a number of years, and I know many clinicians around the country already for a number of years have integrated harm reduction, including for cannabis, in their approach to that issue. But I think there's a lot of work to make sure that we can approach cannabis use in a more flexible way, based on what's the person objective and what are their goals with their cannabis use along their path. So I think that's maybe another kind of more informal, I think hopefully, use of these recommendations and the tools that we.
Can I potentially jump in and add something to what Didier is saying really quick as well? Just in terms of one of the things that I see as like a huge value of the tools, because I mean, I'm a big fan of them. I think that they're so grounded and realistic and attainable. And one of the things that I like about them is that they can be empowering for people who use cannabis and people who experience psychosis as well, to make their own decisions, like particularly like the patient decision aid. And I think like historically, because we've been operating under this like cannabis prohibition lens, it's been like we've been able to just tell people what not to do instead of telling them what they can do. And telling people what they can do is so much more empowering. And I think that often both people who use drugs and people who experience mental illness are often infantilized in clinical settings. And so being able to like empower people to make decisions and be like active participants in their health is just a really great use of the tool. So it's one of the things that I like about it. So I just wanted to add that to what DJ was saying as well, from the perspective of like what I like, for me, what I think would have been like great about having these tools whenever I was experiencing my psychotic episode a few years back. Yeah.
Yeah, thank you both so much for sharing. I think what I picked up, and that what I think is helpful for people who use cannabis, is the inherent flexibility baked into the recommendations. I think the level of evidence that has gone into them doesn't it shows things very clearly, and in a way that synthesizes evidence that makes it a good resource to go for information. But I think this kind of modeled step approach almost into reducing the harms that can be for people who do and don't experience psychosis, and what people can do to minimize the risk. I think that informational piece and that flexibility that's there, instead of kind of being arbitrarily like no, these kind of steps towards reducing, I think they're really good. Did anyone else want to add on this question?
Not
So I
really. I
can,
think everything was covered. Like the points said were pretty valid, and I resonate with them.
wonderful. Okay, so I guess I can move to our next question. So this is for Dr. Crockford. What are the most common first recommendations made if someone is wanting to change their consumption?
Which is a great question, and, and I think I'll just it segues really nicely from what Didier and Heath commented on, is that ultimately the options depend on the person and what their goals are, and we've always known that people change by encouragement and informed decisions. And so taking a very paternalistic or infantilizing sort of approach certainly doesn't work in those situations. And so what we often do, if a person comes in, I'll just ask them, I might pose my concern around their cannabis use if I think that it's related to their psychosis, but leave it up to them as to, to see what they think. And then often in the process, we develop a menu of different options that they can choose from. The idea of like a menu is that if you go to a restaurant and they have 20 different things on the menu, there's probably a likelihood you might choose one from those things. But if you only have one thing on the menu and say it's sweetbreads is the only thing that the restaurant offers, do you like sweetbreads? I don't. And I probably wouldn't go back to that restaurant again. So we want to keep people engaged in the conversation process. But some really basic things can be as simple as initially keeping track. That sometimes people, particularly if they vape, keeping track is really hard because people have their vapes on them 24/7. They actually get more distressed when their vape is out of their hands as opposed to their phone sometimes, and it's tough to know how much one's using. So keeping track, getting an idea of frequency and quantities, and often if they do vape, then not actually having the vape on you is probably one of the easiest things one person can do. We talk about delaying use. So rather than wake and bake, maybe wait a little bit later in the day or after it's 5 o'clock, or who knows. I think Didier really sort of talked about the kind of potency issue, and the dialogue these days is that most people think that 15 to 20% THC is low potency. I mean, maybe I'm a dinosaur, but back before, it was 1 to 2% was cannabis, and 15 to 20% most people would actually view as high potency these days. You can definitely get higher around that, but 15 to 20% is not low potency at all. So wondering about getting lower potency, the tough part is just trying to find it at the store, or having things which are higher in CBD content, but unfortunately cost goes up with CBD. We talk about maybe decreasing frequency. And we're just using in social situations rather than using on their own. Another one is much like the tolerance break, we used to talk about trials of abstinence around it, but tolerance breaks are very similar in that regard. That it takes time to change behavior. And often when people take a tolerance break, they notice things immediately, like their attention and concentration are better, that they have tangible changes that they can notice around it. And then that's my job, is to feed back that to them. And then some people actually are interested in treatment. And so we'll talk about outpatient addiction treatment resources. I work at a concurrent disorder program. So everybody has a psychiatric disorder as well as some sort of substance related issue. And we'll meet people where they're at and talk about what sort of skills are helpful for them to change. And for young people, I find a lot of times that it's doing some role plays because they're around their friends. I don't want them to give up their friends, but if their friends are using all the time, that they don't know how to say no sometimes in those situations. And they'll often start off with, well, I'm trying to cut back. And most people, when you tell them you're trying to cut back, lean over and go, well, one's not going to hurt you. And then you're off to the races again. And so how to have a discussion about I've quit, or the last time I used, I ended up really ill, and I ended up in the hospital and I was psychotic, or I'm on medications. And people end up having this view is like, oh, if you're on a medication, you can't mix it. I was thinking about Didier's comment about the about medications, and it's one of these things that people feel like, oh, if I am smoking, I better not take my antipsychotic medication because it might be a bad interaction. And I advise everybody, it's like, no, keep taking it. Keep taking the antipsychotic. Don't stop it. The only time you wouldn't take it is if you were so intoxicated that you were so impaired that you don't even know which way is up anymore, then you might want to hold off for that day. But otherwise, just take your antipsychotic around it. Those are some really sort of basic things that we often introduce to people, and often they'll pick one maybe from there, and then we can follow up on it.
I'd just like to say, Dr. Hawkwood, that I feel if I were given provided help in such a manner when I was experiencing psychosis, that I were given options, um, uh, I feel my life would have been a lot more different at this point. Back then, I was told I have very few or very limited selection of options, and um, it just makes you feel worse. It makes you feel less in control because there's a big aspect there's a big thing when you think that you're not in control of your mind, and then on top of that you're saying you don't have many options to choose from. It's really disheartening at that point, and I feel just being given that option, these options would be really beneficial. And to your point about being on medication and consuming cannabis, there was this one point in my life where I actually, now this might just be me, but I just wanted to share this, that um, I was, I felt safer knowing that I'm on antipsychotics and while consuming weed, that at least there is a safety net behind me while smoking cannabis, because I felt really scared before doing cannabis, but I just couldn't help myself at that point. And just knowing that I am on antipsychotics, I feel just helped me realize that things might not go as bad as they could have gone had I not been on antipsychotics. Yeah.
I think those are such crucial points, right? Because that sense of loss of control with psychosis is a really devastating impact, and feeling like that's my job, is to help facilitate you feeling like you have control over matters again. And because I can't make a person stop using or whatever, like they're the only person who can, and you having options and feeling like you're capable is so important again. So I like those points.
Great. Thanks for the discussion on this question. It's really important to recognize and acknowledge the challenges in that dynamic and the variability that people can experience, and really sort of work towards reducing stigma and having more trusting relationships. I guess with that, if I can ask Kalpit another question, in your experience, what have been the tension points and challenges related to changing cannabis consumption? And afterwards, we can expand to the rest of the group.
Sure. I actually really like this question. And I mean, because I'm talking about my experience, I feel I can be a bit more free about it. So, in my personal experience, a big problem that I faced was uh, just simply boredom. Um, and I so we talk about how psychosis, and when we talk about psychosis, we mainly focus on the positive symptoms, which are like hallucinations, delusions, paranoia, and stuff. But I feel it's the negative symptoms that made me want to smoke weed. It was the lack of emotions on my face. It was not really, being able to communicate with people properly, not having friends as a byproduct of that, and that caused boredom, and which further caused me to consume cannabis. And I feel that is a big player in me consuming cannabis. I also feel that just uh, just setting up a routine in a certain way where like wake and bake was mentioned earlier. There was this time when I was smoking regularly before I had psychosis that I used to wake and bake, and I would feel odd. It's like having a cup of coffee, I'd say. Like, you feel different if you don't have your first cup of coffee in the morning because it's in your routine. So weed just came in my routine at that point, and it just felt weird not having done it at those certain times. And also, I would like to bring up that point, as Dr. Crawford mentioned, about having low THC options. I personally feel that that's a very true point, because when my friends ask me that, hey, do you want to smoke weed, I say no, but then I try to recommend them that even if you are doing it, try finding low THC options, because like learn from, I guess, my mistake of smoking high THC products. um and it's very difficult to find, because not many stores will keep low THC, high CBD products on them. And this was also mentioned that the price goes up for such products, so it's not always viable for people to use these products. They would think that, oh, what's a little bit more THC? It'll feel better or something, but on the contrary, it doesn't feel as good. So yeah.
Yeah, I think that last thanks for sharing your experiences, and I think a lot of these aspects are common experiences for people who are trying to change their experiences, trying to change their consumption, the varying stages of boredom and changes in how we're feeling. I think that's really critical. I think one of the challenging societal features that we have right now is just how strong available cannabis is, especially from regulated sources. It makes it harder for a lot of people to make decisions that would reduce harms, because there's just such few options that are available there. And it's baked in with social norms and things like that as well, which complicates things as well.
I could
Did
jump in.
anyone? Yeah,
Oh,
yeah, great.
I was going to say, I'm happy to jump in a little bit because there were things that I definitely related to about what Kalpit was saying. And I know that now, like, cannabis is legal and I am like above the legal purchasing age. So I do opt for like products that are lower in THC whenever I can. But I think about like where I was at when I had my psychotic episode and I was like 17. So even if I wanted to be accessing like lower THC, high CBD products that were from like a controlled and regulated source, I wouldn't have had access to a safe supply because I was below the legal like purchasing age. And there are some harm reduction measures, like young people are less like are generally like less criminalized now than they were pre-legalization, and there's like a threshold limit for young people to like be possessing cannabis, but that doesn't like solve the issue of like safe supply to like a harm reduced source of cannabis. So I just like see that as like kind of a barrier sometimes for young people who are maybe like a priority population or like have a particularly like higher like risk when it comes to developing psychosis or psychotic symptoms. But just like bringing it back to the question, I guess, around like changing consumption habits. I know for me, like at the time, most of what I was being told was like, just stop using. And if I had been told, like, consider using less, consider delaying the onset of use or like waiting until you're older, that messaging would have landed with me so much better because it's so much more realistic. And now that cannabis is legalized, it is a thing that you can tell people like, oh, just wait until you're 18, 19, 21, depending what province you're in, or like 25 if you want to be like really careful, but I don't know how realistic that is for most people. But I guess just like that harm reduction messaging would have been so good. But I think based on like what some of the like patient decision aid tools have, like what I ended up doing was like more so tolerance breaks. Like instead of trying to stop cold turkey, I was just like going like 1 day a week. I had like a journal very similarly to like what was developed, where I would like track like 1 day a week I wouldn't smoke weed. And then the next week I would like do 2 days to try and not smoke weed and try and like gradually like taper off my cannabis use. And I found that that helped. But I think one of the biggest challenges, similarly to what Dr. Crockford was saying, like my social group was like largely formulated around like being with other young people who use drugs, as well as like when I was trying to express to them like, hey, I think I am addicted to weed, they were like, hey, that's not like, we do like coke sometimes, like we're doing like speed, like, and you think you're addicted to weed. Like it really was not taken seriously, until like I ended up hospitalized for my psychotic episode because of like the negative effects that I was having and the impacts. But on top of that, I think it was just like a big part of my identity in high school. Like I was a stoner, like it, like, and I think that that's twofold. Like it was something that I was like ascribing to myself because it gave me a sense of community, but it also, I think, was a result of stigma of just being a person who used drugs, and that people saw me smoking weed and they were like, that's a stoner. And then it kind of like reduced me to my drug use. And then suddenly all of the other things that I have had going on, like being in the theater department or playing sports or like any of my other hobbies, were like not as relevant as the fact that I was like a stoner. And so I think that was kind of like another like layer on top of like trying to like manage and like mitigate my own consumption habits. But it's gotten a lot easier as I've gotten older. It was like particularly hard when I was in high school to like manage or like reduce my use. But yeah, I don't know. That's what I would say.
So yeah, thank you so much, Heath, for sharing your experiences. Like the layers in which things are added to the experience and the social levels and identity levels, I think are common experiences that people have. So I think, in particular, getting to share yours makes it's great to hear. I guess with that, I have a follow-up question, or you touched on it a little bit. Through your experiences and just through your advocacy and expertise and knowledge, do you have any tips or things that can make things easier in this experience and going through it, or things that made it harder in particular?
I mean, I think stigma made it harder. I think like intersecting stigmas that I was experiencing, in that like I was experiencing mental health challenges that were concurrent with my substance use, but it was difficult for clinicians to maybe like both like separate them, but also recognize the intersection, because I would be trying to access mental health supports and I would be told like, oh, well, you have to stop smoking weed if you want like to like for the therapy to work, or if you want like us to try prescribing medications, like you have, it was like always abstinence based approaches that I was being given, as opposed to like a harm reduction model. Versus I was like, at the time I was like, well, maybe if you gave me mental health support, it would be easier for me to manage or reduce my cannabis use also if I was given like other coping skills. And I think that's one of the other things too, is that when young people particularly are using cannabis, it's often framed as like a coping mechanism, like particularly for like vulnerable young people or like marginalized or like young people who are experiencing mental illness. It's categorized as like a coping mechanism. It's like cannabis as coping as if it's like a bad thing. But I've like in some of the work that I've done, like we try and reframe it sometimes as like a tool of resiliency, and like recognizing that it is one tool and like you can continue using it in combination with other tools as it is serving you. And maybe by like supplementing the other coping skills and tools that you have in your like toolbox as like a person who is developing skills for existing in the world that maybe is not always accessible for like your flavor of neurodivergence, or like welcoming to the type of identity that you possess as a person, that like it's okay to smoke weed and be mentally ill. And yeah, I think that's one of the other things too. And one of the things that I like about the approach to these guidelines is that they are very much not stigmatizing. Often, and I think it's just because like the warnings on the cannabis labels are just like, cannabis causes like psychosis, or like there's a link between cannabis and schizophrenia. And I think that those are things that are not super well understood, like the distinctions between like psychosis as a symptom of many mental illnesses, as well as like the distinction between like psychosis and schizophrenia. And just I find that sometimes the messaging around that can be at the expense of people who experience mental illness, and like framing it as like a worst case scenario, so that whenever I was 17 and like experiencing the worst case outcome, I had so much shame about it, that it made it like harder for me to get help, and it made it harder to feel like I deserved help, and like it was not my fault that it was happening to me. Yeah, so I think that sometimes some of the messaging around cannabis and psychosis can be like particularly like stigmatizing or border on like being kind of ableist for people who experience mental illness or like are neurodivergent. But I feel like I'm veering a little bit, because I'm like, your initial question, you're like, what makes it easier? What makes it harder? I guess those are some of the things that made it harder. Some of the things that made it easier, I suppose, were like, I don't know, having the support of my family definitely helped. And like some friends, even though they weren't super well equipped and didn't totally know what was happening, as well as like my addictions counselor taking like a harm reduction and like mindfulness approach that was very like client centered and client motivated. Those were big helps. And then also like just doing like getting involved in work like this and meeting other people with similar experiences is always like really supportive. I find like peer-based interventions are great, because then it can be such an isolating experience, but knowing you're not alone goes a super long way, or at least it did for me. So yeah.
Yeah, thanks again for sharing all that. I think we really got some insight into some of the negative aspects that and the things that made things harder for you, especially with providers and beyond that. But I really like the way you framed it, like use contextualizing it as a potential tool for resilience as well. I think as long as like when you're empowering people that way, adding it as a tool in the toolkit, I think is a great way to do it. And I agree with the how these guidelines in particular aren't framed in a stigmatizing manner. And I think, you know, a lot of your efforts and a lot of the work that you're doing is able to help make these discussions, either whether it's for a friend, whether it's for an individual, and for providers as well. So thank you so much for sharing on that as well.
Absolutely. Oh, and I actually just wanted to plug really quick too, because a lot of like the work that I do and like my interest is specifically focused on like young people. And similarly, like there's like the general cannabis use lower risk guidelines. There's also like lower risk cannabis use guidelines for young people specifically. And now there are these ones that are specifically around psychosis. So there's like a handful of tools that you can pull from, and there's a lot of overlap in them. But I think like looking at the lower risk cannabis use guidelines for young people and the lower risk use guidelines like for psychosis in combination with each other could be potentially of particular interest for a handful of people maybe watching. And I encourage people to consider that also. So thank you.
Awesome. Thanks so much. So for everyone in the audience, please, we're welcoming questions in the chat. At any point, you can throw those in. I have one final question prepared, and I guess we'll start off with directing to Dr. Didier. What can and should clinicians be doing to best support youth with psychosis who use cannabis?
I'd say the first step, I think, is take a step back. Take a step back from because as clinician, we've been trained. I've been trained. I don't know, I cannot speak for David, but we've been submerged with actually scientific data and guidelines saying that, you know, we should make young people or people with psychosis stop using cannabis. And I think that we need as clinicians to take a step back, look at the data, and actually I think that the recommendation are a way to do that, but also just to take a step back about this practice and rethink a little bit how we want to more globally and broadly approach cannabis use with people who are using cannabis. One thing that I really liked, and both Kalpit and had to talk a little bit about it, but we're so trained, especially as clinicians, to look at the problems, the risk, the negative outcomes. That also, I think it also changes a little and has an impact on the way we approach cannabis use, where we're often very focused on the problems and the negative consequences. And I'm not saying that there's no negative consequences related to cannabis. Of course, there are some, but I think sometimes we don't pay enough attention to just take a step back and understand what's the place of cannabis in the life of the person I'm talking with. And I think that's super interesting. And Kalpit also mentioned what was the cannabis was just not purely a risk for psychosis or a substance that led to psychosis. Cannabis had another role in their life. And I think that being able to grasp and understand actually the perspective of the person we have, and then we're trying to help about their cannabis use more broadly, not just in terms of risk, I think is very useful. And then after that, and I think that's also the lens of the perspective, the recommendation is that I think adapting the objective of the work we're doing with people who use cannabis and have psychosis to actually, and having a common goal that sometimes and often is not necessarily abstinence, I think is more productive and also much more satisfying as a clinician. I don't know a lot of a clinician who wants to impose thing or try to convince someone that to do something that they don't want to do, and being able to have that dialogue around cannabis in a way that is more respectful, having a common goal, trying to reach those goals together, I think is so much more productive and also satisfying as clinicians. So I think those are on top of what we discussed today, kind of other take home and ways, I guess, to approach cannabis use, even with people who use cannabis.
Can I just say something like from my personal experience? Like Dr. Didier, you mentioned that coming up with goals, like common goals. I feel it's also important for both the parties to realize that if those goals aren't achieved, that is also fine, because there's a high, like at least for me, there's a high chance that I set goal is like I'm in therapy every week and I set goals with my therapist every week, and sometimes I reach those goals and sometimes I don't. But like when I don't reach those goals, it's very difficult for me to go back to the therapist because I haven't reached those goals, because I feel that I've disappointed the other person and let them down in some way. So I feel if that is made clear with youth here, that hey, even if you fail, it's completely fine. We're born to fail and learn from our mistakes. Like maybe even a similar approach to that can be really beneficial.
Thank you, Kalpit, for saying that. And I think there's a lot, what you said, I think there's so much wisdom in what you said. And for clinician, I think it's good to hear. I can also share my experience also that with the goal setting and what I mentioned, my experience actually with the people I've been helping over the years is often that the ultimate goal and the long-term goal that person end up having is often not the first one that we set up together. And sometimes there's kind of a try, sometime not necessarily achieving that first goal. And that experience actually helps the person, I found, help the person to find actually what's their real objective, whether or not it's changing or not actually their cannabis use. So I like your way of looking at these goals, but reaching those goals or not, it's not about failure. It's about learning along the way. And I think clinician, we have to be, I take that from what you said, we have to remind ourselves that also the way we react to these initial goals and whether or not that person reached that goal is very important, and that it can have an impact on the person. So I like what you said, and I'll definitely take that on with me.
I could actually add one other quick thing too, which I guess like it's just similar to what's already being said, but just encouraging like this like shift